Hey everyone, good morning. I don't know if you can. Morning, Josh. Morning. Thank you all for joining me this morning. And we'll get started in a few minutes, so if you'd like, just post up your questions in the chat or board. Help if I was on the correct board. I got the right one. Joining me. And don't forget we have a quiz next week, so it'll be basically covering what we did last week. The day most, I guess, of mostly the endocrine and the nephro. So I'll delineate that further when we get with Jerry, I suppose. Right, so it's just about 8. So let us begin. Any questions from anyone before we get started? Assuming everyone is just got this down. Everyone's just mastered this information, which is fantastic. My job's so easy. Tell you what. Yeah, of course, anything you want, post it up. I don't mind talking about it. So we were talking about. Actually, I should start recording here. Hey, Madeline. All right. So we were talking about chronic kidney disease. We were talking about some of the issues that pop up with them, including things like, I'm glad you're a pro, Joshua. That's fantastic. I love the confidence. Um, but we were talking about some of the issues they run into in terms of like metabolic complications, like their decreased erythropoiesis and things like that. I want to talk about the kind of bone and mineral disorders that they run into as well, which can be pretty detrimental. So one of the things we're going to find is that they again are going to have elevated levels of phosphate, which can bind to calcium pretty readily. So it's kind of interesting because sort of early on you'll see they have like a hypocalcemia due to the phosphate binding everything up, and then later on they'll develop sort of hyperphosphatemia and hypercalcemia, along with hyperparathyroidism and all kinds of issues related to that. So we want to try to normalize and try to interrupt this cycle that's happening here, and try to decrease a lot of those like extravascular calcifications that occur there, decrease sort of the bone issues that pop up, things like that. one of the things we try to do, and again, you'd like to get your patients, electrolyte levels within the normal quote unquote range, but that may not always be super feasible. So oftentimes what we shoot for is to have a calcium phosphate product less than 55. And so that's pretty easy to calculate. You just put their calcium times their phosphate. The value is less than 55. You're generally in a good range. Once you start to get above that, that's when you can run into challenges in terms of that calcification. And then, of course, you're monitoring your PTH levels as well and hopefully normalizing those. First thing you want to do for these patients is to try and limit their dietary phosphate intake. That really should be the first thing, because if you can decrease the amount coming in, that can help out in terms of, because it's harder to eliminate it in kidney disease, and you'll find that dialysis doesn't really pull it off all that easy there. So the challenge, though, is that, these patients typically have a little bit higher than usual protein requirements. They are sort of like kind of metabolically stressed, and if they're on dialysis and things like that, it can be a bit of an issue. So that's a challenge. But if you can cut out other high phosphate foods and drinks out of their diet, that can be useful. So things like dairy products and colas and beer and all that kind of stuff tends to be a little bit higher in phosphates. So again, it's a delicate balance in the protein intake, and then trying to limit their phosphate as well. So as I say here, dialysis is generally insufficient to correct phosphate alone, which is why we got to focus on it from the intake side, not just on the elimination side. Dialysis is pretty good for a lot of other electrolyte disturbances, sodium, potassium, magnesium, things like that. But phosphate just isn't one of those that is going to be quite as easy there. And then for some patients who we can't get their parathyroid, hormone levels in check, we just can cut out the whole thing if you need to. But hopefully that'll be, sort of a last ditch sort of effort there. First thing we can do is try to bind up the phosphate in the GI tract and prevent it from being absorbed in the first place. And so this is where we have a couple of our phosphate binders that come into play here. The first two are going to be sort of the easier ones to do, and can be good if your patients have low calcium levels, because you'll get some absorption of this here as well. So we have things like calcium carbonate and calcium acetate. Calcium carbonate is just the normal Tums that you would be able to find over the counter. So, pretty easy and low cost to get a hold of. Calcium acetate is another variety you may see being used. That's actually a prescription product called Foslo, specifically used just for that. Again, no specific reason why you need one versus the other. It just depends on, maybe how the patient's responding. You might have a little bit difference in GI side effects, things like that. Recall that constipation is going to be a pretty big issue with calcium-containing products. So, of course, if they're on other meds that can slow down the GI tract, that can kind of compound on itself. And then we have three other ones we can use here. So if their calcium is an issue in terms of being too high, then you can use a non-calcium-based phosphate binder. And again, these are all oral products because they're binding a phosphate in the GI tract. So things like sevelamer carbonate and then lanthanum carbonate, the Renvela and Fosrenol. Those are pretty commonly used if the patient's calcium levels are high and you want to get the phosphate down. That is what you go with as an alternative to the calcium-based ones, because they're going to be more expensive and all of that. But otherwise, they're pretty well tolerated. And again, you want them to take it with meals, because that's when presumably most of that phosphate intake is going to be happening there. The last one you can use here is aluminum hydroxide. This is something you want to be careful with, though, if they have, if they're on end-stage renal disease, if they're on dialysis, you may want to avoid this one, because you can actually develop, you can actually hold on to aluminum and develop aluminum toxicity, which is a neurotoxin, which is not generally a problem for most patients. But again, the more severely deficient in terms of renal function, that could be a risk there. So that one we'll save in case they're not really responding to anything else, then we could utilize that. So again, as I mentioned, calcium ones are good if they're initially hypocalcemic, so usually early on in CKD. And again, you'll find that the things like calcium carbonate tend to be a little bit more soluble. The calcium itself is more soluble in acidic mediums, and so that's why we give it prior to meals, when you're presumably releasing most of your stomach acid at that point there. And as I said, with sevelamer, that's good if you have patients who have hypercalcemia. You don't want to raise that up any further. Just note that you can have some cholesterol changes here, which tend to be pretty beneficial, if anything. And then generally avoid the aluminum in case, unless anything else is failing, then you can use that as kind of a last-ditch effort. So generally speaking, with the phosphate binders, the adverse effects are GI in nature because again they're orally taken. So constipation, diarrhea, potentially like aluminum hydroxide, you could see that. Tend to be pretty consistent. Hypercalcemia is only going to be an issue for calcium carbonate and acetate, and then the aluminum toxicity is obviously only an issue with aluminum hydroxide. Um, Interestingly enough, the aluminum can actually interfere with absorption of iron. So in those cases, there you can actually worsen the anemia, which we mentioned is a problem for these patients anyway. So again, that's another reason why we like to hold off on that unless we absolutely need to use it there. The other big thing you're going to run into is going to be the food drug and drug interactions here. And again, those calcium salts are going to bind up to a lot of stuff. So zinc, iron, fluoroquinolones, tetracyclines. And you can see how these patients' regimens can get pretty complicated if they're having to separate all these different things out that may interact with one another. So it's a challenge. So what you can do is either take the interacting medications an hour before the phosphate binder or about 3 hours after the phosphate binder. In those cases there, then you can, there'll be enough distance in between them in terms of where they're at in the GI tract. They shouldn't really interact with one another. So that's kind of the goal. And generally speaking, if you have those type of drugs, are going to be interacting. Now, vitamin D therapy is another important component here because again, the parathyroid is going to be responding not only to levels of calcium, it's also going to be responding to low levels of vitamin D as well. Madeline's asking, can the phosphate binders be consumed via an NG tube, or what products do we use for patients who are on NG tubes? That's a good question. You'll find that that may be dependent on formulation, and it also can be dependent on what else you're putting in the tube there, because again, you could precipitate stuff out if you're giving it at the same time as the feeding or the feeds. But a lot of them you can just crush up and you can place into the actual tube itself. I'm not sure specifically about lanthanum and cevelum, but this is stuff you can honestly look up as well if you go like your LexiComp and things like that. So I'll pull up the page here in just a moment. Just try. So yeah, so here's a good example here that I'll show you. I think it's a good example. You guys will have to own decisions there. Oh my goodness. Trying to make it big for you guys and then lost my spot here. Hold on. Technical difficulties this early in the morning. So you can see here, and I apologize if it's a little bit small, but but basically what you can see here is that all of these drugs will have like an administration section, and you can look up like the oral administration thing here. So for instance, this one says, okay, immediately with or after meals. Talk about the chewable tablet, don't swallow it whole, chew it up so that way you can, have a bigger surface area and bind up with that phosphate a little bit easier there. You notice here there's an oral powder, right? So this is usually going to be an easier case where you can actually administer this with something like an NG2 if you were to mix it in applesauce or something like that. So that's sort of the things you kind of think about. And there are even like special books you can find that kind of tell you more specifically about like NG tubes and things like that. Yeah, so that'll be a little bit more kind of like specialized information, but generally speaking, as long as there's not any kind of like a solubility issue, most things, if they can be crushed or suspended in water or placed in like some kind of medium like applesauce or something, generally speaking, you're pretty good to go from that standpoint there. But yeah, there could be some special things that will like clog up the tube in some cases, and that's usually due to insolubility with other stuff. So yeah, and again, not something I deal with every single day because I'm trying to think. Most of my kids at the hospital with chronic kidney disease that are on phosphate binders, they typically don't have NG tubes. I think most of them probably have pretty functional GI tracts. But you'll certainly see that in more elderly patients for sure. It's just I don't deal with those patients as often anymore due to where I work. So anyway, So vitamin D therapy, as we mentioned, is very important for these patients here. Typically, when you're intaking vitamin D from your diet, it's either ergo or cholecalciferol, so D2 and D3, or D3 and D2. I get the two confused a lot of times, but honestly, it doesn't matter clinically too much. I'm sure there's probably someone out there who's probably yelling at me, but um, the big thing though is that both of these can be converted to the active form through a two-step activation process. So through the liver first, and then the kidneys, and so it gets this these two hydroxylation steps that happen here. So by the end of it, when you come out of the kidney, you have the active 125 dihydroxy vitamin D. So it's calcitriol is the name of that, and we can give the patient straight calcitriol. It's called Rocotrol. You can see here, and it's more expensive, but you can do that if you needed to bypass the patient's kidneys, which presumably are not functioning here. Again, even if you stuck your dialysis patients out in the sun for a while, that vitamin D is not activated. They can't activate it due to that kidney dysfunction. So what you end up finding is because of that, you will, by giving them the active form, you can help to suppress PTH secretion. You're also going to find it stimulates calcium absorption. And so the challenge is early on, that may be a good thing when they may be hypocalcemic. But as time goes on, because of the effects that vitamin D has in terms of like reabsorption in the kidneys and absorption from the GI tract, that cannot be great because it can actually worsen hypercalcemia and hyperphosphatemia for patients who are a little more progressive. So again, if you had a patient who is already hypercalcemic or hyperphosphatemic, calcitriol is probably not a good product to administer to them because it could, it'll lower their PTH levels, but it's just going to worsen their other, those electrolyte abnormalities there. Some things that can help, though, to kind of bypass that include a drug called paracalcitol, which is otherwise known as Zemplar. And these actually will activate the PTH receptors and make them think you have enough active vitamin D, but it doesn't increase the calcium or the phosphate absorption. So it's actually pretty good because it kind of tricks the parathyroid into thinking there's more vitamin D there than there is, but you don't get all the GI effects and kidney effects you would see normally with active vitamin D. Kind of neat. Other things you could do include a drug called cinacalcet or Sensipar. This actually is going to sensitize the receptors of the PTH or parathyroid. So basically, they will be more sensitive to the calcium that's already there, and so should decrease your PTH concentrations as a result of that. So just another alternative. I see probably more paracalcitol than I do cinacalcet, but I'm sure there's some situations where that's going to be preferred. I just don't see it too often. Okay, so that's kind of it for the nephrology section, kind of just mainly focusing on the sort of the chronic kidney disease aspects of it, since that's kind of where the most place where we have opportunities to kind of manage those patients from a medication standpoint. To switch gears, now we can talk about some of the urology aspects of things. And so the first thing we'll talk about here is going to be erectile dysfunction and sort of the medications we can introduce to try to help out with that. Basically, what we will define this as is the inability to achieve an erection that's sort of suitable for intercourse for about the period of like 3 months or so. Sometimes you'll hear this termed as impotence. But keep in mind that there are different sort of issues that can arise here, right? So if someone comes to you complaining of not being able to have sex with their partner, it could be an issue of maybe they don't want to have sex. So maybe it's a libido problem. Maybe they're having infertility issues and they can't get pregnant. They can have sex, but they're unable to, conceive a child. So these are different problems, and they could have different reasons for them, and it's important to delineate those. Because you may try to treat it with one thing when really that wasn't the best option to go with. And so we'll kind of go over a few of those different options there. So basically what you're seeing here, looking at sort of a cross-section of the penis here, you can see the two corpus cavernosum. That's going to be important for basically where you have like blood flow coming in and causing the actual expansion of the tissue to occur. That'll be important for some of our medications that are actually administered intracavernosally. We'll talk about that a little bit later. But generally speaking, during the more flaccid state, you're going to find that there's a balanced inflow and outflow of blood from the venous and arterial sides. And during the erection, you're going to find that there are certain changes that occur, namely with vascular either dilation or constriction that's going to basically lead to increased arterial flow and decrease venous flow, right? So that way you have more blood coming in than going out. So that's how I developed the erection there, which is again why, for instance, I'm sure if you've ever seen commercials for like Viagra and things like that, they say, oh, call your doctor if you have an erection lasting for more than 4 hours. You're like, what's so special about that? Well, the issue is that, if you have, and that's called priapism, you have an erection that does not go away. The big issue with that is if you don't have enough blood flow coming through, then you don't deliver enough oxygen to that tissue. It can start to necrose and cause permanent damage. And so that's why priapism is considered a urologic emergency. It has to be dealt with either by drainage, or you can do certain vasoconstrictors to help out with that. But we'll probably touch on that a little bit later on here, since that is a risk for some of the medications that we can give for this. So how does that arterial flow change? Like, what is actually happening from a sort of biochemical basis here? Well, basically what we're seeing is that when the patient has stimulation for an erection, they're either seeing some sort of external stimuli or some sensation, there's going to be sort of a complex interplay between the brain down to the penis, including acetylcholine activating these receptors that are going to cause vasodilation. Once that occurs, you're going to see upregulation of a couple of different cyclic messengers like cyclic GMP and cyclic AMP. A few other things as well, like vasoactive intestinal polypeptide, but we're going to focus mainly on CAMP and cyclic GMP. Okay. One of the big things that happens here is that cyclic GMP is going to basically decrease the amount of calcium flowing into the vascular smooth muscle. So less calcium coming in means less constriction of that smooth muscle, right? Because all muscle requires calcium in order for it to contract. By removing that calcium, it's going to relax that muscle. It's going to allow for more blood flow coming in. You also find that acetylcholine, or in some cases prostaglandins like PGE, it can actually enhance cyclic AMP, which does a very similar action there. And so we get into the medications, we're going to find there's two different pathways we can target, either cyclic GMP, cyclic AMP with our medication. So again, it's important to have that psychogenic stimuli, right? So you see someone who's attractive or something like that, for that sort of reflex to occur in the first place, which is why you can find patients, for instance, that have like spinal cord injuries, like they can develop impotence because they don't have that signal being sent potentially, depending on the nature of their injury there. We're also going to find the hypothalamus is really important for integrating that external stimuli, right? So that way, if you see something that's very attractive to you that would normally generate an erection, to actually integrate that is through the hypothalamus. And so you're going to find that you have different neurotransmitters that can affect that as well. So for instance, dopamine actually exerts sort of a pro-erectogenic effect, right? So you can imagine some people might have some issues with that, including people who are on dopamine antagonists. But people on antipsychotics may complain of sexual dysfunction because they have this dopamine blockade happening here. Or alpha-2 stimulation can inhibit this. So we already have drugs that can inhibit or actually activate alpha-2 receptors like clonidine and guanfacine. So that would have a negative effect on their ability to generate a suitable erection as well, right? So again, you can already start to see some of the drug interactions that can lead to erectile dysfunction. And again, the answer might not always be to give them more medications to treat their ED, but it may be to remove medications or to switch them to other medications that can help to limit that. So when you have detumescence, or you're going back to the flaccid state, that's going to be mediated through norepinephrine, and that's actually going to contract that vascular smooth muscle. So then you have now new balance between inflow and outflow of blood, and then you're going to find that will also increase the venous outflow. So then you go back to the normal flaccid state, which is interesting because actually if you have priapism, which I'm not going to talk too specifically about here, but if someone who has priapism, you can actually inject phenylephrine, which is a pure alpha agonist, to basically get the same effect here. So that's one thing we can actually do from a medication standpoint. Now, other things that can be playing a role here include the hormonal effects. So testosterone, which we've discussed previously when talking about it during like the endocrinology section, generally speaking, decreases after the age of 40 or so, starts to trend down. And this is important for stimulating libido, right? So your patient's complaining of having sexual troubles with a partner, ask them like, okay, well, do you even want to have sex, right? Because that could be a whole host of reasons for that, including low testosterone levels, could be due to depression, could be due to lots of things there, right? Recall that 5-alpha reductase is going to help to convert testosterone over to dihydrotestosterone. That's going to be important when we're talking about prostate in just a little bit. Prostate is, we're going to find, is really important for um, uh, generating seminal secretions, and so that can actually lead to ejaculatory disorders you can find there as well if that's going to be a limited supply. So we'll get more into that. We talk about BPH in a little bit here. But you also find some of that testosterone does get converted over into estradiol, right? That's a normal process, that aromatase enzyme. So if some patients may be getting a little bit too much estrogen sort of effect, and that can affect their libido as well. So overall, it's important to just be careful when trying to interpret testosterone levels, because some patients may have normal levels and still having issues. You may have to look at things like free levels, and focus on whether it's more of a decreased libido issue. They just don't want to have sex, they don't care about it anymore, or whatever the case may be, versus true erectile dysfunction where they want to have sex but they're unable to generate that erection suitable for intercourse. So again, asking questions, getting good history will help to uncover that sort of stuff pretty easily there. Someone's asking, did you give cinacalcet only in addition to rocatrol, similar to paracalcitol, or is it beneficial on its own? So I generally will see those patients with chronic kidney disease will typically be on one of those three. So they'll either be on the calcitriol, they'll be on the paracalcitol, or they'll be on the cinacalcet. Typically, it's not like one plus the other, because at least specifically with the calcitriol and the paracalcitol, they're kind of doing the opposite effect there in terms of, both will reduce PTH levels, but, one can lead to hypercalcemia and hyperphosphatemia in the calcitriol, versus the paracalcitol should help to lower that, because it doesn't really act the same quite as active vitamin D in the gut and in the kidneys there. So again, it's an either or sort of thing, and can be beneficial on its own. So hopefully that answers your question there. Okay. So in terms of the pathophys and how erectile dysfunction can develop, there's lots of reasons for this. It could either be a vascular issue, so things like PVD or arteriosclerosis. It could be a neurologic problem, so if someone's had a stroke, diabetes can lead to this, spinal cord injury, certainly hormonal issues in terms of like aging, hyperprolactinemia, right? Because that's going to have a negative effect on dopamine, right? Because high prolactin means you have low dopamine, vice versa. That can be an issue there. And then sometimes it's just kind of organic. It just kind of happens, idiopathic in some cases there. But be aware of it, whether or not it's psychogenic as well. Like, is it just like maybe they just don't have the right external stimuli that is normally what would stimulate that? Maybe they're having other issues in terms of, depression or anxiety, or all kinds of things that could be certainly influencing this. And it really could be multifactorial. But remember, the patient in the baseline needs to be sort of in the proper mental state there, right? So again, if they're having reactive depression because maybe they're not performing well with their partner, and that's causing frustrations, if they have performance anxiety, again, if you're having performance anxiety, you're usually in a pretty hyperadrenergic state, releasing a lot of norepinephrine. We know that inhibits erections, right? Because you're in a fight or flight state. You don't need to necessarily have sex when you're in that mindset. Alzheimer's disease, mental disorders, things like, bipolar disorder or schizophrenia, things like that. All of these can lead to, certainly issues in terms of developing erections. So you want to find out, okay, can I deal with one of these first? Can I treat their depression? And that fixes all the other issues, right? That's going to be beneficial. Now, of course, you want to look at their medication list to see if anything here could be influencing this. And so there's lots of drugs that could be leading to issues. And so you want to be able to identify those and either switch them out or get rid of them entirely if at all possible. So in terms of anticholinergics, this will certainly, because we saw acetylcholine initiates this whole sort of reflex process. Anticholinergics are going to be sort of antithetical to being able to develop an erection there. So generally speaking, if you can use things like second generation antihistamines like phenidine or loratadine, and from a antidepressant standpoint, again, typically TCAs are going to be the worst for this in terms of causing erectile dysfunction. Your SSRIs will be a little bit better, but they kind of cause their own host of sexual dysfunction there. Oftentimes, patients just don't want to have sex. SNRIs, but then bupropion has the best effects in terms of causing sexual dysfunction. So bupropion has the least risk for causing sexual dysfunction for these patients here, and it's a common reason why you might need to switch a patient from like a TCA to bupropion or a SSRI to bupropion. Uh, Dopamine antagonists can do this, as I mentioned before. So things like phenothiazine, so all of your antipsychotic drugs, metoclopramide. Again, by blocking dopamine, you increase those prolactin levels, and that can also have negative effects on testosterone. So it sort of has multiple features there, blocking dopamine in the hypothalamus, decreasing testosterone production. So again, those sets of drugs can be sort of multifactorial in terms of how they cause erectile dysfunction. Anything affecting testosterone can lead to issues here. So things like giving estrogens, anti-androgens, which we're going to get more into detail here when we get into like BPH in a little bit. Spironolactone for sure. I know we've talked about before how that can overall decrease androgen activity in patients who are typically at higher resting levels of testosterone, and even things like ketoconazole and cimetidine that can actually inhibit sort of the metabolic processes that go into producing testosterone in the first place. And again, by suppressing that testosterone, you're decreasing that libido, so they may just not want to have sex anymore. The biggest thing you're probably going to run into most frequently, especially for younger patients, I would imagine, are going to be CNS depressants, right? If you are CNS depressed enough to where you're about to pass out, obviously you're not going to be able to respond to those external stimuli very well. So again, if it's an issue of they're taking benzos or opioids or ethanol can be a common culprit for this, and even anticonvulsants. Again, they're going to suppress that perception of those external stimuli, right? So someone may be trying to initiate sex with that patient, but again, if they're so, kind of zonked out from the medications or from the alcohol, they may not be able to respond to that. So of course, those are all questions you need to ask in terms of like, well, what kind of mindset were you in when this happened, and what was sort of the surrounding events that can try to clue you in to see kind of what's actually happening here. Another big cause for this, and again, this is why we talk about the medications, because the answer is not always to add on more meds. Sometimes it's trying to get rid of meds or trying to switch them. But in these cases here, anything decreasing penile blood flow can certainly lead to issues here. So a lot of diuretics can do this just by decreasing blood volume. Beta antagonists and central sympatholytics, like clonidine, beta blockers, all of that are going to be decreasing arteriolar flow to the corpus cavernosum, right? Drugs that are going to be better for this from a blood pressure standpoint include your ACE inhibitors, your ARBs, and your calcium channel blockers tend to be better for this, right? So again, if I asked a question on a test and I said which one of these are least likely to cause erectile dysfunction, I could put something that blocks androgens. I could put something that's like a blocks dopamine. I could put a beta blocker on there, and then an ACE inhibitor. Say, okay, well, I know these other three cause erectile dysfunction by X, Y, and Z reasons. The ACE inhibitor is going to be less likely to cause that. Okay, let's do that. Other agents too, just kind of miscellaneous ones, include things like lithium. We'll talk about finasteride and dutasteride later on. Those actually block production of DHT, which we'll get into. So lots of things that can cause this, and it's always good to look it up if you're not sure to see if there's any reported incidents of this. So make sure to go ahead and get a thorough history from your patient, medication list, and all of that, along with any kind of concomitant disease states. Certainly things like diabetes can complicate this. You'll be doing your testosterone levels, physical exam, all that good stuff. So you guys know how to get an assessment out of a patient. But let's talk about the treatment here. This is mainly going to be medication based for the most part. Our goal here is to get an increase in quantity and quality of suitable erections for the patient. We also want things that are going to be well tolerated. You're going to see some of these options may not be as well tolerated as others. Make sure patients only have like legitimate complaints. You'll find that some of our medications here kind of have a reputation. They can help as like performance enhancers, and so you may find like younger patients who don't really need it are trying to get access to it, which can lead to some issues in and of itself. It's kind of interesting because a lot of the medications, and again, you think it's kind of funny because Viagra, I think, is probably the most known medication used for erectile dysfunction. We stock Viagra at Nemours, and you're like, well, why would you do that? Why would you have an erectile dysfunction medication for kids? And it's because it helps out with another disease state. I'll talk about what that is in just a little bit here, but we actually keep sildenafil, or at a time we kept it in the vault alongside all of our controlled substances because there's concern for people who could be diverting that for their own personal use or selling it or something like that. So it's kind of interesting how different places may control it differently depending on the situation there. But you always want to assume the best out of healthcare workers, but not everyone is on the up and up, as it turns out. Anyway, so you'd like to correct the underlying condition if you can. So if they're smoking, if they're drinking too much alcohol, things like that, all can be very beneficial here. And then from a actual treatment standpoint, we're going to see there's options for things like vacuum erection devices. There are pharmacologic therapies, which I'm going to be focusing mostly on here. And then surgery can be an option as well. And so we'll look at some use cases for each of these to see who might be a better candidate for one versus the other. But if you can get rid of the underlying issues first, that's always going to be helpful. I apologize, my phone's set to vibrate. I don't know if you guys can hear that or not. Very unprofessional of me. I apologize. Let's set my phone anymore. Okay, there we go. So generally speaking, we want stuff that's going to be less conspicuous. Things that are going to be cost effective and have limited side effects or drug interactions. We're going to see some pretty significant ones here in just a little bit, but we'd like to try with the least invasive things to more invasive. So generally speaking, if you can just pop a tablet in the mouth, that's very least invasive, or more, that's going to be the least invasive option you have there, as opposed to things like injections, pump devices, things like that. So we'll look at some different options there. Voice picture sure is small. Size of that better. So basically, what we're going to be seeing here is if you have your patients starting out with erectile dysfunction, again, treat the underlying conditions, remove medications that could be contributing, all that good stuff, right? If they do have hypogonadism, you can always replace it with exogenous testosterone. But generally speaking, we're going to be starting off with our phosphodiesterase inhibitors, or if you hear me say PDE inhibitors. That's what we're talking about there. We'll get into those in just a moment. And then we're going to see that if patients if it's effective, you're good to go, right? You don't have to there. But we'll find that there's just some things we can do to try to maximize the use of those PDEs to see if we can become effective for your patients. We'll find that if that's not going to work, we can utilize things like intracavernosal or intraurethral prostaglandins. Again, I'll talk about here in just a little bit. And then if they're contraindicated, or if they prefer, they can use things like vacuum erection devices, right? It's like a penis pump, basically. And then if that's still not effective, then that's when we can start to consider things like surgery options, so things like penile prosthetics and things like that. So we'll get into some more details here, but you can refer back to this to see the general flow in terms of like when you're going to pick one drug versus another. This kind of helps you to kind of get a clue about that. So I'll very briefly talk about the vacuum erection device. Again, this is outside of my wheelhouse. We don't deal with this very much anywhere that I've worked, but certainly could be an option. Certainly not the most discreet option that's out there, because again, it's a whole device you have to use and all of that. But basically, by using negative pressure, it can draw the arterial blood into the cavernosa. It's pretty effective, but again, it's going to be one of those things where I think patients may be kind of taken aback if you were to like kind of recommend that. But for some people who cannot receive other medication therapies, this could be a good first step for them. It may be used prior to things like surgery potentially. So again, probably not ideal for every patient, but I'm sure there's some subset who that's going to be a good option for. I'm going to focus on the meds. So here we have the phosphodiesterase inhibitors. We're going to see here that let's say kind of walk through the steps here of developing an erection from a biochemical standpoint. Starting off, you have sexual stimulation of the patient, right? You're going to find that reflex arc is going to be activated that sends acetylcholine down into those nerves, innervating the vascular endothelium. What that's going to do is release nitric oxide, okay, so NO. Nitric oxide is going to then be used to generate cyclic GMP because it generates or activates guanylyl cyclase. So nitric oxide activates guanylyl cyclase that converts GMP into cyclic GMP, or GTP into cyclic GMP, I should say. And then that cyclic GMP blocks calcium influx into those cells, that vascular endothelium. Blocking calcium means you're going to get relaxation on that smooth muscle, and that's going to allow for increased blood flow. Well, what do you need to do to go back to the flaccid state? Well, you have to get rid of that cyclic GMP, and that's where you can utilize phosphodiesterase. Phosphodiesterase will then convert a cyclic GMP down into GMP, and then you can go back to the normal flaccid state there. What we can do, though, is try to inhibit phosphodiesterase so we keep more cyclic GMP around for longer, thus increase the chance that they can develop a suitable erection there. Madeline's saying they use the vacuum after prostate cancer for penile rehab. A lot of the patients would fail out and turn to meds. Interesting. I don't have much interface with those patient populations. That's pretty interesting there. Yeah, because I mean that's one of the big things you'll see, especially if they have like a prostatectomy or something. The sexual dysfunction is pretty common with patients there. But it's interesting. They're using that for them. So cool. Thank you for giving me some new perspective on things for sure. Anyway, so our main phosphodiesterase inhibitors we have here include sildenafil, vardenafil, tadalafil, and then avanafil. So everyone, I'm sure, knows Viagra, the little blue pill. It was very popular when it first came out. Because again, we didn't have a lot of good options other than like intracavernosal injections or these vacuum erection devices or surgery. So, this was pretty popular when it came out because you're like, oh, I can just pop a pill and then, you're good to go. Basically, what this does is that it's going to be sort of an analog of cyclic GMP that's going to kind of keep that phosphodiesterase busy and keep it from actually breaking down your natural cyclic GMP. And so, and that way it keeps those levels higher. So you're allowing for more, less calcium coming in. So you're getting that vasorelaxation that's happening there, and you can develop the erection. Now, one thing to note with phosphodiesterase is there's not just one kind. You have lots of different kinds of phosphodiesterase throughout the body. The main one that's going to be seen to be used here specifically for generating erections is PDE5. Okay. So the reason why I mentioned we have sildenafil in the hospital, the kids' hospital, is actually because PDE5 is not just like predominantly found in the genitals. You can find it up in the lungs too. And so the same thing happens if I increase cyclic GMP levels in the lungs. Guess what happens with blood vessels? They open up and it allows for better blood flow through. So we use that for cases of pulmonary hypertension, and we use this a lot, especially in patients who have congenital heart defects. That we'll use that in order to relax that vascular smooth muscle in the lungs and allow for better blood flow through, so you get better oxygen exchange and all of that good stuff. So again, you're like, well, why would you ever give a little girl Viagra? That's specifically the reason why. She probably has pulmonary hypertension. Now, there are other types of PDEs we'll get into, and that's going to lead to some of the side effects that are going to be sort of unique to the PDE inhibitors here. Here is a quick table to sort of give you the breakdown and differences between the various phosphodiesterase inhibitors we have here. The 3 varieties of PDE that we're going to focus on include 5 for our therapeutic purposes. Also, C6 and 11 are going to be are going to be responsible for some of the side effects we're going to see here. And again, you'll see that not every phosphodiesterase inhibitor is same, because some of them will have more effects on things like PDE6. Some will have more effects on PDE11, and that can lead to specific side effect profiles that we're going to get into that are sort of unique to them. Other things you're going to see that are important include things like the half-life. How long do these drugs stick around for? So you can see here, most of them are between, 3 to 4 hours or so. However, like tadalafil lasts like 18 hours in terms of a half-life. So you can be getting a lot longer duration of action out of that potentially there. So those are kind of little things we're going to look at. And again, onset of action is important to look at too. So again, does it, when should they be taking this prior to intercourse? 30 minutes, 60 minutes, things like that. Those are kind of some of the key points we're harping on here. Christine is asking, so the PDE5 causes relaxation of the muscle. If so, in pulmonary edema, why are you inhibiting it? Am I understanding this wrong? So, so not pulmonary edema, but pulmonary hypertension, right? So pulmonary edema is when you have fluid on the lungs. This is pulmonary hypertension, where those vessels are too constricted and it's not allowing for good blood flow through the lungs there. So you end up getting those VQ mismatches with ventilation versus actual oxygenation. And so you see this a lot of times in patients with like congenital heart disease who have, or sometimes like CHF, you'll see this. They have like left-sided heart failure. But basically what you're finding is that you are impeding that blood flow through because those vessels are so constricted. So by giving the phosphodiesterase inhibitor, you're going to be able to relax that smooth muscle, open up those little vessels, and allow for more blood flow to go through. So that's why we do that. That doesn't make sense, let me know. Unless I misinterpreted your question potentially, but just let me know. Anyway, so your PDE inhibitors are typically first line for most patients here, especially younger patients. It's pretty discreet. You can just pop a tablet, very easy to do. And so your selection will typically be dictated by adverse effects, onset, duration, cost of treatment, all of that. And I'll get into each of those kind of points there in just a little bit. And again, cost has gone down as time has gone on because of generics being available and things like that. But I remember this is when I go into Old Man Wood talk, but I remember back in the day when I was an intern in pharmacy school and I was interning at a CVS, and you had these guys who would come up with a prescription for the sildenafil, but their insurance wouldn't cover it because it was seen as more of like a lifestyle kind of medication, and so the insurance didn't want to cover it, and it was pretty expensive. And so this wasn't like a very affluent part of town, so these are people with limited incomes, right? And so these guys would come in and they would basically say, just give me 2 tablets, right? It's like $50 or something, or something even more than that, depending on the tablet. And that's all they needed because again, they're usually picking up on Friday evening, going out, doing the thing over the weekend, and then that would be kind of good for their particular lifestyle. So cost is really important here. It could be pretty much a limiting factor there, depending on things like insurance coverage and things like that. Most of these are going to be pretty effective for most patients. If you find that they're failing phosphodiesterase inhibitors, is generally speaking going to be due to things like comorbid conditions or other medications that might be on there. So, but for the most part, people tend to respond pretty well to this. If they are having failures, it's generally going to be due to things like how are they using it? Are they using it effectively? So, for instance, here things like food interactions, so sildenafil and vardenafil. If we go back to this page here, seeing fatty meal decreases rate of oral absorption, right? So for vardenafil and sildenafil, if say for instance you're going out on a date and you decide to get a nice big greasy hamburger and you're like, oh, sex might be happening in the next 30 minutes or so, you pop your sildenafil, that can slow down the absorption. So then by the time it's time to perform, that drug may not have fully absorbed just yet, right? So those are kind of things you can educate about, is that, hey, maybe instead of that big greasy hamburger, have a nice light salad. Perhaps that will help out with the absorption. So again, sometimes it helps if you kind of know the timing of things there a little bit. But other things to consider too is, give them about 5 to 8 doses or so before they can say how well it's going to work or not. And then avoid obviously excess alcohol, which is, something you see a lot of times on date nights and whatnot. That will help out with sort of that external stimuli processing and all that there. Generally speaking, if you have patients who have issues of like blood flow problems, so if they have like sickle cell disease, leukemia, things like that, or if they're on other erectile dysfunction therapies, you want to avoid mixing and matching these because that can increase your risk for priapism, which, as I mentioned, is a urologic emergency because you don't want to damage a tissue by not delivering enough oxygen to it. You also want to avoid in healthy patients. So unless they have like a legit need for it, so if you have like 22-year-old college student who's using it for performance enhancement, that's probably not the best patient for it, and if anything can increase your risk there for priapism. Not to say that no one like that would have any issues, but it's less likely in that group there. And I think one sort of misconception with these tablets here is that the second like you give the pill, is that all of a sudden you just have like an erection and you just stuck with it for the duration of action of the drug. You still have to have the external stimuli. Like you still have to have that sort of stimulation in order to develop the erection in the first place, because this just helps to facilitate that biochemical process of generating that cyclic GMP. If there's no reason for you to generate that cyclic GMP in the first place, because there's no external stimuli sort of telling you, hey, it's time to have an erection, it's not going to do anything. Okay, so that's kind of one thing that I think students have misconceptions about. I had the same misconception when I was in school too. I was like, okay, well, just walking around with an erection for that long, but that's certainly not the case. So some of the side effects you're going to find with the other PDE isoenzyme, so 6 and 11 are going to be the big ones that we're concerned with. PDE6 is predominantly found in the rods and cones of the eye, and so you can see blurred vision if you start to inhibit this enzyme. You can also develop a unique side effect called cyanopsia, which is a bluing of the vision. So basically you have a decreased blue-green color discrimination, or decreased ability to discriminate between blue and green, and so it looks like everything's kind of turning blue to some degree. This is sort of similar to when we saw xanthopsia, or yellowing of the vision, with something like digoxin, right? And you'll see that sildenafil is going to be much more likely to cause these problems here than you will see with the other agents. So this is primarily a sildenafil issue, but it could happen with the other ones, just less likely. PD11 is primarily found in the striated muscle, so skeletal muscle, and if you inhibit this, it can lead to myalgias. And so tadalafil is going to be the big offender here in terms of causing myalgias associated with PD11 inhibition there. So those are kind of things you want to know. Sildenafil, you think PDE6. Tadalafil, you're going to think PDE11. Okay. So in terms of onset of action, we're going to see that again, if you consume sildenafil and vardenafil within 2 hours of food, that's going to slow down the onset of action. Let's see. So Christine's asking, if you don't get stimulated and you're on sildenafil, will it just sit there until you are, or is it removed naturally? No, I mean the drug gets processed to the liver and gets eliminated just like anything else, you know. So, say for instance, if your drug is going to have a duration of action of say 8 hours or so, right? If you never got any kind of stimuli during that 8 hours, the drug would still get processed away. Problem then again, the patient may have never developed an erection during that time frame. So it just depends on the situation there. Generally speaking, though, patients will have some sort of anticipation of, sexual activity when they're taking these, because they're not going to be taking this around the clock unless they had something like pulmonary hypertension. And then in that case, they may see more chronic use. But for patients using it specifically for erectile dysfunction, again, they're going to be using it with the anticipation of sexual activity. So they'll, have a time frame in mind they're thinking about, and they'll take it. So again, you could say they date nights of 6 p.m. or something like that. They could take it like an hour beforehand, and then they'd be fine. It's just when they're consuming with food, it'll slow down the onset. So again, they just want to be something to consider, right? So they can try to plan out their night a little bit better there. Tadalafil does have a slower onset, but it also lasts a lot longer. So some people can take tadalafil on Friday night, and it lasts them basically throughout the weekend. So that can be some sort of effective from that standpoint for them. A lot of these are metabolized through CYP3A4, so you can have some drug interactions you'd want to watch out for there in terms of like inhibitors, making the drugs more effective or more likely to cause side effects there. So you should note that. And then if they have renal dysfunction, then sildenafil and tadalafil have to be adjusted there. So a lot of the side effects you're going to be getting with these drugs here are going to be related to the smooth muscle relaxation, not just affecting the genitals or the lungs. They can affect other things as well, right? So for instance, if I start to dilate the vessels up in the brain, that can lead to headache, right? Just like we saw with migraines previously. You see things like facial flushing, because those small vessels in the face can start to dilate and become hyperemic. You see dyspepsia, and that's related to relaxation of the smooth muscle of the lower esophageal sphincter. Right? So nasal congestion, dizziness. And again, all dose related. So higher the dose, more likely you are to see that start to pop up there. And you can see some drops in blood pressure, right? They can affect your vascular endothelium elsewhere. And so most of the time this will be asymptomatic, but the people you want to be really careful with are going to be those who are on other antihypertensives or if on nitrates. And in general, we're going to find that nitrates plus your PDE inhibitors are going to be a big no-no. We're not going to want to combine those. And if you have a patient who's like a really high-risk cardiac patient, probably want to avoid these or use very cautiously in cases there. Also think about it too, patients having sex or physically active, that may be something that could trigger, if they have like myocardial ischemia or, if they have, atherosclerosis or something like that, you could see how that can induce a cardiac event potentially. So that's something you got to kind of think about. From other adverse effect side standpoint, as I mentioned, I talked about the cyanopsia, the photophobia, blurred vision. That's generally going to be more of a sildenafil issue. Although the other ones can cause it, just is less likely. One really big warning thing you want to note here is if the patient has any sort of blindness associated with this, which hopefully most patients would freak out. I don't know if they became blind in one eye. They call 911, but this is called non-arteritic anterior ischemic optic neuropathy. It's rare, but basically you can find you'd have this loss of blood flow going to the optic nerve, and that can lead to a unilateral sort of blindness there. And then if left alone, without treatment, could be irreversible. So this is something you certainly want to say, stop taking the med, get to the ER, hopefully get an opto consult, and hopefully it will kind of reverse on its own. Otherwise, you could see permanent damage done to that nerve there. So rare, pretty rare, but can still happen. So tadalafil being that it can inhibit PD-11, you're going to see things like back and limb muscle pain, up to about a third of patients there. And again, that may be a reason to discontinue it or switch over to another medication in this category potentially. Vardenafil can cause QTc prolongation, so you'd want to be watching for that if you're mixing and matching with other drugs. They can also prolong QT. And then priapism is rare, but typically seen with like higher doses. As I mentioned, those patients who have, like blood flow issues due to things like sickle cell disease or leukemia, things like that, or if they're on other erectogenic drugs. go over some of those here in just a little bit. So those are things you want to be watchful for. So drug interactions, this is a big one, is that if you combine these with nitrates, cause severe hypotension, because now you have drugs that are inhibiting phosphodiesterase, so the erectile dysfunction meds, and then now you're also giving more nitric oxide or nitrates, which basically generate nitric oxide. So those two together can be really synergistic, and so you can see really big drops in blood pressure, right? So why would this ever occur, right? Well, imagine this. Imagine you have, let's say, an elderly gentleman with a history of MI, potentially, right? So he's having intercourse with his partner. He'd taken a phosphodiesterase inhibitor earlier. All of a sudden, he's being physically active. All of a sudden, he has chest pain, right? Let's say he calls 911, EMS shows up, and they go ahead and say, okay, you're having chest pain here, take some nitro. All of a sudden, his pressure bottoms out. Now he's delivering even less blood flow to the heart. Now you've worsened your problem, okay? Another hypotensive. So that's why it's really important to ask these patients, hey, have you taken any medications for erectile dysfunction recently, right? So generally speaking, within 24 hours for most of them, 48 hours for tadalafil, because it does have a longer duration of action there. And generally speaking, don't mix and match the two together, okay? So if you had someone who had received a PDE inhibitor within 24 hours, I would not give them a nitrate. You can do other things to get their blood pressure corrected. You can do other things to help out with that blood flow to get the oxygen back to the heart. Nitrates are not going to be the best one. If you do have someone who has that combo and they were bottoming out, things you can do include putting them in Trendelenburg position, where it's going to be their feet up and their head down, basically. You can position the bed to try to get more blood flow going to the brain and the heart. And then you also give them isotonic fluids like normal saline that can try to help tank them back up, because those vessels are going to be wide open, so you want to fill it with something like water or salt. So, and then the other big thing to watch out for is if they have 3 or 4 inhibitors on board. If so, and you can't discontinue them, then you can use lower doses of your phosphodiesterase inhibitors when starting out, and just kind of be more cautious and see how they respond to it. So that's it for the PD inhibitors. Kind of more complicated than you might have thought, based on just they're used to give you an erection, but it's a little bit more complicated from a biochemical standpoint and drug interactions and things like that. In terms of other things we can use to treat these patients here, that can include prostaglandins, so PGE1, or alprostadil. This is kind of interesting because alprostadil is another med we use IV a lot for neonatal patients. It actually helps to, we have a patient who's just born, helps keep their ductus arteriosus open. So sometimes you'll see that like in the NICU being used, or for babies who are just born that have congenital heart defects or things like that. But what we can do here is we can use an intracavernosal injection called Caverject or EDEX. That's one form you can give it through injection, or you could use an intraurethral insert. So it's basically a small urethral suppository that can be placed intraurethral, and that can then melt and then be absorbed in the local tissue. The thing with this is that PGE1 or alprostadil is going to be working on cyclic AMP instead of cyclic GMP. So this is good for patients who may have a history of being on nitrates, or they may have a history of myocardial ischemia where they may receive nitrates due to chest pain. In this case here, this bypasses that by going the cyclic AMP pathway. Again, it still does the same thing as cyclic GMP. It's just going through a different pathway there, and is not nitric oxide dependent. Right? That's why it's good for those patients there. Other people who could be good for include those who might have failed phosphodiesterase inhibitors, the diabetes, prostatectomy, things like that could be a good option there. Sylvina saying, would you have an inhibitor, an inducer of a CYP enzyme? Which medication wins? I don't know. I just watched Godzilla versus Kong last night, so perhaps it's a tie. Perhaps one wins out. I think a lot of it depends on how strong of an inhibitor or an inducer it is. Can depend on the dose of the medications. Unfortunately, it's one of those unsatisfactory, it depends kind of answers there. But it really would be so dependent on the situation, and it would be very hard to predict. I would say avoid mixing the two together if you can, but sometimes you got to do what you got to do. So it really just be very situational and dependent. But thank you for the thought exercise. Let's see here. So anyway, you'll find the intracavernosal tends to be more efficacious than the intraurethral. mainly because again the bioavailability is better because you're injecting it directly into the cavernosa where it's going to be used there. Um, we used to use other agents, things like papaverine and phentolamine, but we actually found that those had a much higher risk than things like priapism. So we went ahead and said, okay, we're not going to use that. Now prostatil is the main one we're going to see there. Yeah, it was actually pretty. I mean, it's going to a 30-second Dr. Wood movie review. It is very good for what it is. It's not going to be thought provoking. It's not going to be something to where it's going to change your life by any means. But it's just a good popcorn movie. I thought it was very good for what it was. Let's see. Someone said here. What's up with ED meds that are sold at sketchy places like gas stations? What are in those? Oh boy. So those are generally going to be herbal supplements, which is why they can get away with selling them in gas stations. Um, I know that Yohimbeam is a common dietary supplement you can see that can stimulate or is purportedly used to help stimulate erections. You might find other herbal supplements that are in there. I'd have to look at the packaging though to see on what they're including. I just know Yohimbeam is a common one. I'm trying to think of any others off the top of my head, but honestly, I haven't looked at it too recently. Generally in gas stations, I'm just there for the gas and not for much else. But yeah, you never know what's in that stuff. I would be certainly cautious, especially since a lot of those products, even though they say it has this many milligrams of X, Y, or Z in it, may not always be the case, right? Because again, they're not held to the same sort of labeling standards as FDA approved drugs. To say that all dietary supplements are not like that. There's certainly more reputable brands than others. Just the gas station brands, I don't know how much I would put credence in them. I mean, they used to sell bath salts and K2 and synthetic, cannabinoids and stuff like that when it was available. So I don't know necessarily what their supply chain looks like for that kind of stuff. You need an icy or Slurpee though, best place to go, right? So, um, anyway, so what we're gonna see here is that we're giving these pretty small doses because again, it's just working very locally. The other benefit to that is it's not going to be working systemically, so you're going to see much fewer systemic side effects by using medications here. So, and typically you're going to find patients have more of like a psychogenic erectile dysfunction. So if it's like due to like depression and things like that, it responds better at lower doses than you would see with patients with like more of a vascular issue. That kind of makes a sense there. And tolerance doesn't really appear to develop, so this can remain effective for as long as the patient's going to be using it, basically. So why do people discontinue use of this, and why don't we use it at first line? Mainly because of inconvenience, right? So having to inject yourself or having to use this urethral suppository, I imagine sounds pretty daunting to most patients. And again, it's much more labor intensive in terms of you have to like clean the area with the alcohol swab and you have to drop the medication and inject it and all of that. Some people may be very needle phobic. Some people may have just lost interest. These are typically older patients at a point, I imagine, in life, you're just like, I just don't care about sex anymore. And it could be related to cost as well. These will generally be fairly expensive because, again, it's an IV product. You have to buy the supplies to go with it and all of that. Right? So basically, the patient will inject just into one cavernosa, and then the duration of action is quite short. So it's going to be a duration of about not much more than an hour. So again, they need to kind of have an idea of when sex is going to be initiated, and that way they can know when to use the medication there in conjunction with that. Again, the onset should be about 5 to 10 minutes prior to intercourse. As you can see, that's a much shorter lead time than you would need for something like a phosphodiesterase inhibitor. We need about 30 minutes to an hour or so. You'll see here we're going to be using a pretty high gauge needle here. Remember, the bigger the gauge, the smaller the actual diameter of the needle there. So 27 to 30 gauge is quite thin, and pretty short needle there, just a half an inch, because again, we're not having to go very far into the tissue there to get into that cavernosa. Another thing to consider too is use aseptic technique, because again, you don't want to get any kind of like skin infections related to that. So again, could be a lot of education for the patient in terms of how to inject safely. Consider to are they able to do it themselves? Do they have like the physical dexterity to do this, or do they need their partner to help out? Things like that are all considerations. Let's see here. Look at my stream went out for a second there. Adverse effects you can see is basically a lot of local pain, irritation. This will typically improve as their injection technique gets better. In some cases, you can have these like fibrotic plaques that will develop. So in those cases, there you can just let them give it time for them to go away, and then you can continue injecting afterwards. Priapism is not super common, but can range between 1 and 15% there. Again, so that's something just to educate about. If you have an erection more than 4 hours and you got to come in and all that kind of stuff. But generally speaking, it's a factor for what it does. It's just a matter of like, trying to convince your patient, hey, you have to inject yourself now. They may not be down for that necessarily. With the intraurethral injections, this one again is very technique dependent because you can find urethral damage, which can lead to things like strictures. So again, administration technique is very important to make sure that's get it on. Now you can always go with the prosthetics, and so again, I don't deal with these patients very frequently because of the fact that it just wasn't really in my wheelhouse being in the ER. Certainly see priapism that would come in. Certainly see plenty of cases of trazodone causing priapism and overdose. But I had a student not too long ago that was at a urology clinic, and they said most of the older patients that came in, they're like 70, 80, like they just said, put in the prosthetic, and they got the malleable one. And they thought it was great. They found very satisfied with the results there. So it just depends on your patient, and if they want to skip the meds, they want to go with the surgical option. That could be totally up for them if they're good candidates for that. So anyway, I'm just going to focus on the meds because surgery stuff I don't know nearly as much about, at least from a actual procedure standpoint. All right, so let's talk about BPH. Got plenty of time here. So BPH is going to be something we see again. It's kind of like a more male sort of focus lecture here. We're going to find that with BPH, again, we're getting an enlargement of the prostate, or we're having some sort of constrictive action on the prostate that's impeding urine flow through the urethra. And so this is a pretty common problem, especially for older men who are prostate is growing. And there's several things we can do for them, including see how symptomatic they are. Sometimes you don't do anything. Sometimes you don't just do something, stand there. And do the watchful waiting approach. And then we have plenty of medications we're going to be focusing on what we can do here. And then surgical options as well. We're going to see that's going to be not the most ideal situations. If they can keep their prostate, that's usually a good thing from, a sexual function standpoint, from, other reasons as well. So the prostate here is basically this, it's a chestnut-sized gland. I don't know if I've ever seen a chestnut in person, but I don't really have a good size comparison there. But you're going to see that it kind of has two big growth phases. So initially during puberty, and then as men get older, you'll find that it naturally just kind of grows in size as time goes on. And its main function is to provide some of the fluids needed for ejaculate, basically. So about 20 to 40% of those fluids come from the prostate there. Also kind of interesting is, why are, male patients typically less at risk for things like UTIs? One of the reasons is because of the high zinc content in the prostate actually provides some antibacterial action as well, which is kind of neat. But yeah, so what we're going to see here is that it's going to be made up of several different tissues. And so basically there's the epithelial tissue. This is sort of the glandular tissue that produces the secretions. This is going to be stimulated by androgens, so namely testosterone and dihydrotestosterone, which we're going to see here in a minute. There's the stromal tissue, which is going to be embedded with these alpha-1 receptors. When you activate those alpha-1 receptors, it's going to cause constriction of the prostate, which can impinge on that urethra. And then there's a capsule as well that has some adrenergic receptors as well. So it's important here, don't get confused when we're talking about androgens, which are like testosterone, and adrenergic substances like norepinephrine. Okay, we're going to kind of keep those two separate in our minds here because they do different actions. Oh, someone's trying to hide their sticky note way down here. Yeah, so how do the malleable inserts go from flaccid to erect when needed? My understanding of this is limited, but my understanding is it's almost like, I don't know if you guys ever played with like those Barbie dolls that have like the bendable limbs. It's kind of like that. That's as far as I'm going to go because I don't want to speak outside of my expertise, which is very, very shallow when it comes to penile prosthetics, I would say. Just not something I'm going to be all that too knowledgeable on. However, you can always go to Up to Date. They have lots of good options or lots of good articles there you can check out and see. That's going to be something that will help you out with your understanding. But I can guarantee you there's going to be 0 test questions about any kind of penile prosthetics. Probably not going to ask too much about the pumps. mainly the meds we're going to be focusing on here. Okay. I'm not going to ask you questions on things I don't even know too much about. And again, the amount of stuff I know is could fill many libraries. Anyway, so again, kind of keep it straight here between the androgenic portion here, which causes the prostate to grow, to become bigger, versus the adrenergic receptors here, which are going to cause it to squeeze. Because you can find prostates can either have one or both of these problems, where it's either too large and that impinges upon the urethra, it's too constricted, which can impinge upon the urethra, or it's both, right? And so that'll dictate which kind of medications we're going to use here. So one of the big stimulants to grow the prostate includes testosterone, and then by converting testosterone through an enzyme 5-alpha reductase, it converts it to DHT, or dihydrotestosterone, which is actually more potent of an androgen than testosterone is. And so this causes typical things like acne, male pattern hair growth, and again, it is going to be a strong stimulant to induce that prostate enlargement. You will find that some of the testosterone that male patients make do get converted over into estrogen via the enzyme aromatase, and that can cause some stromal growth as well. So again, you can find both of these factors playing a role here, but we'll see that DHT for patients who have prostates are going to be much more important here. So to get into that more specifically, there's what we call static factors versus dynamic factors. Static factors meaning that things aren't really changing very quickly. Dynamic factors mean they can change fairly dynamically, very quickly there. So static factors are typically due to enlargement of the prostate. So again, how large is that prostate and how much is it physically impinging upon that bladder neck, leading to that obstructed urinary flow, right? This is mainly due to androgen stimulation on the epithelial tissue via DHT, and some estrogen stimulation on the stromal tissue. It's a minor effect, but it can occur. The dynamic factors are due to excessive alpha adrenergic tone on that stromal tissue, the bladder neck, all of that. And this can be triggered because, again, it can happen. You can change quite quickly. It can either be due to like stress or pain, things like that are going to be primarily we're going to see those changes there. So you can see symptoms from the static and or the dynamic factors there. And so it's important to kind of get an idea to see, okay, well, what's primarily causing the problem here, and that's going to dictate what medications you're going to be using, right? And again, you can tell the things like prostate size based off of doing it like a digital rectal exam, things like that. And that can give you an idea, okay, we're dealing with quite a large one, because that may lead you to picking one medication class over another versus if it's normal size, things like that. So that can give us some ideas on what we're going to do. So what are some reasons patients could have symptoms of BPH but due to maybe other medications, or maybe these medications are causing their BPH symptoms to become worse? One thing we can see is if they're receiving any sort of like testosterone replacement or any sort of exogenous androgens that can to some degree be converted to DHT, or they could directly stimulate that stromal tissue there that can cause it to grow. So that could be one thing. Adrenergic agonists, so things like Sudafed, phenylephrine, ephedrine, can all directly activate these alpha-1 receptors, so that would cause more of a dynamic issue. And then anticholinergics, this can be seen with the antihistamines, your first-gen antihistamines, phenothiazines, TCAs, all of that. This is basically causing relaxation of that detrusor muscle on the bladder, right? So by relaxing that, you're actually going to cause more urinary retention. So not directly causing any issues on the prostate, but if you have more, if your bladder is relaxing, holding on to more urine, and you're also blocking the outlet due to the BPH, again, you can see how they can kind of aggravate one another there. So your symptoms can mainly be obstructive in nature here. So we call this either bladder outlet obstruction or prostatism. Another name you'll see that for that. And basically, you're seeing decreased urine flow rate. You'll see bladder emptying may be either slow or incomplete, and they may have things like urinary hesitancy. Over time, you can end up getting bladder overdistension because they can't really get enough flow through, and that can lead to some of these what we call irritative symptoms. They're going to be seen later in disease, and this is just due to that long-standing bladder outlet, the bladder neck outlet obstruction, basically. So over time, you're going to see things like the bladder muscle becomes hypertrophy because it's having to hold on to so much more. And so because of that, you can see hypersensitivity of the bladder. Because again, normally you can store quite a bit of urine in your bladder because as it starts to fill up, it will relax and stretch receptors on it won't be activated as much up to a point, right? If you have this bladder that is much more sort of thick and hypertrophied, it's going to get that stretch receptors being activated much earlier, and so that can lead to a lot of that urgency and frequency you can see there. And so it just becomes really ineffective at storing a lot of urine. That means they're going to see things like incontinence. You can see things like nocturia. And again, a lot of times for these older patients as well, this may be the thing that sort of leads them to need to be institutionalized, like going into like a nursing home or assisted living facility. And typically, those patients don't like do a whole lot better when they get to there. They can get infections, and being moved out of their environment can worsen things like dementia. So again, it's kind of it could be good for them from a standpoint if they need the extra care, but if you can try to prevent this would be beneficial most of the time. So for a lot of patients, symptoms might not always be progressive. You can do kind of a watchful waiting sort of approach there. You may find some people either stabilize or improve without treatment. It just depends. But certainly if they start to develop those lower urinary tract symptoms, more of the irritative symptoms, that can lead to things like UTIs. It can lead to things like neurogenic bladder. So those are things we're trying to prevent if we can. So again, depending on their symptomatology kind of dictates whether or not we're going to start with the medications, and we'll see which ones we can try there. Other complications include things like, urinary retention can lead to renal failure, right? That's kind of a post-renal sort of issue there. You can see things like bladder stones, you can see chronic renal failure, all kinds of problems that can happen here. So we want to try to inhibit this as best we can. So here's a good table kind of showing you the step-by-step process on how we would basically go through and decide how to treat these patients here. So let's say they have BPH, we made the diagnosis, and so if they have more mild symptoms, you can just do the watchful waiting approach, right? So if it's not really bothering them that much, you don't necessarily need to do anything right away. If they have more moderate symptoms, we're going to see that if they have erectile dysfunction concomitantly, we can actually utilize our phosphodiesterase inhibitors for some extra help here. We'll look at that. We'll see that if they have a small prostate, that our alpha agonists, or antagonists, are going to be useful here. If they have a large prostate, then we'll look at some use of our 5-alpha reductase inhibitors. And then they're having these irritated symptoms, we're going to look at using a combo of the alpha adrenergic antagonist and the anticholinergic drugs. Now, again, we'll get into all these in more detail here in just a little bit. So this is a good review slide to go back and see how you're going to utilize these different classes of drugs based off of kind of what the presentation is. And then again, for severe symptoms, this is where we can consider things like prostatectomy, minimally invasive surgery. Again, I'm not going to get in depth on that because, again, it's not really my purview. So our desired outcomes here are to try to prevent disease complications. Hopefully, if we can reduce the need for like surgical interventions, utilize therapy that's going to be well tolerated and cost effective as always. So things we can do to try to relax the prostate smooth muscle include alpha 1 adrenergic. Spell that right? Adrenergic antagonists. These will be used most commonly. Note that these reduce the dynamic factors, but these do not do anything to prostate size. Okay, these just block those alpha 1 receptors and allow the prostate itself to relax on that smooth muscle there. If we can reduce the testosterone or the androgenic stimulatory effects of things like testosterone DHT, that's going to help to reduce the static factors, and this is going to shrink the prostate. Okay. And so we're going to use our 5-alpha reductase inhibitors to help out with that. We'll get into those drugs specifically here in a little bit. And then for those later symptoms to try to reduce those irritable symptoms, we can use antimuscarinics that are going to help to relax the bladder. That'll become more important when we talk about things like urinary incontinence here. So how we choose our drug is going to be on a more case-by-case sort of basis there. And again, typically the benefits are only as long as the medication is being taken, right? So the prostate is enlarged due to the patient converting a lot of testosterone to DHT. You can inhibit that for a while, but if they stop taking the medication, they're going to go right back to their baseline. That prostate will then grow back to its normal size, or the size that's normal for them based on the amount of androgens they have available to it, right? Generally speaking, we're going to find the alpha 1 antagonists have better side effect profile, and they also are more rapid acting. So they're generally going to be considered first line. But if they have a particularly enlarged prostate, or maybe they have like a high risk cardiovascular history, In those cases there, you want to use a 5-alpha reductase inhibitor. And I'll talk about the reasons for that in just a little bit. But some cases you may need to use both, right? So you may need to go with both classes of drugs here. If they have erectile dysfunction and BPH, you may find phosphodiesterase inhibitors can be useful here. Although overall, they're less effective than some of the other agents. So this may be like a useful add-on, but probably is not going to be used first line in a lot of cases. And then, as I mentioned here, with the irritated symptoms, anticholinergics are going to be used. We'll get into those in more depth when we get into the incontinent section a little bit later on. Just have to make sure the patient doesn't have a high post-void residual, because that can lead to them holding on to even more urine, and again, that can worsen symptoms from that standpoint. So, let's see here. So in terms of our alpha-1 adrenergic antagonists, we have a couple of different classes here. There's sort of like 3 generations. The first generation ones had such bad side effects, we don't really use it anymore. But basically what these drugs are doing is to block alpha-1 receptors. That's going to cause relaxation of vascular smooth muscle, right? The thing you're going to find that with a lot of these early generation ones is that it doesn't just affect, the prostate, it can be affecting all your blood vessels, right? So what you normally expect to see is that when you have decrease in your systemic vascular resistance because you're relaxing blood vessels, you're going to see that the heart is going to have a reflexive increase in heart rate. And so tachycardia may be a common side effect you can see with these alpha-1 blockers. With the first generation ones, it was so severe that you saw a lot of tachycardia and arrhythmias related to that, so we don't use it. Okay. The second gen drugs are going to be less side effect prone from that standpoint. You're going to be less likely to see as much tachycardia. But then the third generation ones are going to be what we call uroselective, meaning they're specifically going to be activating or blocking alpha-1A receptors. And those are more predominantly found in the prostate than you're going to see on the blood vessels. So the benefit there is they're getting more specific. It's generally a newer class, and more likely to see more like, kind of expensive brand name drugs. We'll look at some different options here. In terms of efficacy, though, the second and third gens are all equal. It's just that the third gen have fewer side effects. Okay. Also note, none of these drugs here listed are going to have an effect on prostate size. It just helps with the constriction of that smooth muscle on the prostate. So the second gen ones, we've actually talked about these before. Most of them we were talking about antihypertensive meds. We know these are not great as antihypertensives because they're pretty limited in terms of their actions. They'll definitely drop the blood pressure, but your body responds to that and has those compensatory mechanisms, so it makes them not great for hypertension. But we have things like prazosin, parazocin, doxazocin, and alfuzosin. Some people may say like prazosin or terazosin. I don't really care how you say it. Either one is going to be fine here. Main adverse effects, and these are, again, the high-risk cardiac patients are who you want to be careful for here, is that you can see things like orthostatic hypotension, right? So patients going from sitting to standing, all of a sudden, all those vessels are dilated. They can't really control where that blood flow is going, so you have transient decrease in CNS blood flow, so they pass out. You're going to be really careful. They get dizzy and fall. And again, these are typically older patients you're using this for, so they may have less homeostatic reserve to respond to that change in blood pressure quite so well. So again, you gotta be careful, because if you have these older patients, they get dizzy and they fall, they can break a hip, they can break a femur, and again, that causes all kinds of worse problems for their morbidity and mortality down the road, right? So generally speaking, because BPH is sort of a slow onset sort of disease, we have time to work with this. This is not like an emergent thing we have to treat right away. So for the second generation in alpha-1 blockers, basically we want to start low and go slow. So over the course of a couple of weeks, we also want to dose this at bedtime, so that way any sort of like orthostatic hypotensive effects are predominantly going to be happening at night when they're sleeping anyway. So it's less likely to be a problem. Just be careful if they're the type that have to get up to go to the bathroom a lot in the middle of the night. Hopefully this will help to limit that, because again, their prostate is not going to be quite so constrictive on they should be able to void better, right? You'll find this has synergistic effects with other antihypertensives, so maybe if their blood pressure is not under control normally, this can be useful. And we typically avoid prazosin because it has a shorter duration of action, so I have to take it like 2 or 3 times a day, so it's not great. You also see a lot more like kind of peak dose cardiovascular effects. We don't like that quite as much. You'll find doxazocin and alfuzosin are going to be more long-acting medications here, so those are beneficial from one compliance standpoint, and overall they're going to have kind of like lower average serum concentration levels, so they're not going to be as bad for causing that orthostatic hypotension. And then we're going to find alfuzosin out of this bunch here actually has the lowest incident of systemic side effects and doesn't actually require any dose titration, which is kind of nice from that standpoint. So that one is probably the safest out of the bunch listed here for just the second gen alpha 1 blockers. Now we do have some third gen alpha blockers here. And their claim to fame is that they're specifically blocking alpha 1A. So they really shouldn't have very much effect on blood pressure. They really should just be affecting the prostate specifically. So silodosin is not used very often because of a lot of drug interactions and whatnot, but tamsulosin or Flomax is used all the time. So this one you do want to avoid if they have a sulfa allergy. So one thing to note there, and needs to be taken on an empty stomach to get good bioavailability there. But the benefit here is going to be blocking the alpha 1A receptors, and it really has almost no hypotension. Not really going to see a lot of effects systemically, mainly just going to affect the prostate. Some of the side effects you can see, though, it can include things like some flu-like symptoms, like some nasal congestion, because you can see a little bit of alpha 1 blocking effects there in the nose, causing some congestion, and anejaculation due to its inhibitory effects on the prostate. So those are the big things to see there. Again, if I had a high-risk cardiovascular patient, I'd probably either go with alfuzosin or tamsulosin first line. Now, you may see sometimes tamsulosin being used for female patients. You may be thinking, like, well, why would you use it for female patients? But you can actually use it in cases of things like kidney stones. This can help to relax some of the urethral smooth muscle and allow for better passage for stones and things like that. So sometimes you may see it used in the case of kidney stones, which is seems like a pretty common thing here down in Florida since our water is full of calcium. But anyway, other things we can do include the phosphodiesterase inhibitors being used if they have concomitant erectile dysfunction. You'll typically see that if you're starting to mix and match the PD inhibitors plus an alpha blocker, you can see some synergistic drops in blood pressure, but this is limited if you use something like tadalafil and tamsulosin, because again, they both have longer half-lives and they're also not going to be affecting the blood pressure quite as much. So that would be the safest combo to use out of the bunch here. Now on the other side, we could do something to try to decrease the androgenic effect of testosterone and DHT on prostate itself. And so this is where our 5-alpha reductase inhibitors come into play here. These basically, will decrease the amount of DHT that you're forming by inhibiting 5-alpha reductase. There are, different isoenzymes of 5-alpha reductase. I'm not going to get real into the weeds in terms of that, mainly because it's not as clinically relevant as it was for something like, phosphodiesterase. But the big things here is you're going to see that, in the prostate, you're going to have big drops in DHT levels, but you're also going to see this systemically. So from a side effect standpoint, this is going to be much more intensive than you're going to see with something like, tamsulosin, right? You're going to see a lot more systemic side effects here because it's dropping DHT levels pretty significantly. But the two we have here include finasteride and dutasteride. These are better for patients having large prostates. It can slow down that disease progression, hopefully some of those complications there. Either of these are fine. They both work equally well here. So this is going to be good for patients who cannot tolerate alpha-1 antagonists, but sometimes you'll see them used in combination, right? So they're having both kind of static and dynamic issues there. You can use a combo. And this can reduce the prostate size by about 25% or so. And they do see a decreased prevalence of prostate cancer, so that could be another little bit of a side benefit of the drug there. Just note that it's going to be much slower in onset because, again, it's not like the prostate is going to shrink or grow very quickly. It's going to be a little bit, it may take a few weeks before it really kicks in. Certainly going to see a higher incidence of things like sexual side effects like decreased libido and ejaculatory issues. And so if they're still sexually active, this is going to be more of a second line set of drugs. Okay. But again, I can give you plenty of like patient vignettes on the test to say, hey, which one of these would you want to go with first? And these are kind of the things you want to think about. Say they're sexually active, no cardiovascular history, alpha-1 blocker is probably a good option. Versus someone who has had history like 2 MIs and they have a really large prostate, something like 5-alpha reductase inhibitors is going to be much better bet for those type of patients. Okay. These you can use long term. Just realize that prostate size will go right back to baseline once you remove it because the patient is still producing the same amount of DHT that was not there. As I mentioned, you can have issues of ejaculatory disorders due to decreased secretions. And there may be some issues in terms of nitric oxide synthase actually being inhibited there, so that could also be a reason why you may want to use this along with like a PD inhibitor to kind of help out with that. And then overall, because you're dropping DHT levels, you can see things like decreased libido. So it could be multifactorial in the case of something like this. Other adverse effects you're going to run into include things like nausea, vomiting, headache, gynecomastia can be expected here, because one of the things to consider too is that by dropping your DHT levels, if you can't convert all that testosterone to DHT, then what's going to happen to all that testosterone? Well, some of it's going to get converted into estrogen via aromatase, right? So in those cases there, you can see some feminizing side effects here. And in fact, there are some use for these 5-alpha reductase inhibitors for transgender patients. So someone who's transitioning from male to female, they may actually utilize something like a 5-alpha reductase inhibitor in order to drop those DHT levels, in order to increase some of the estrogen production. And that maybe is a form of hormonal treatment for those patients there, which is really interesting to see. Just know this is also going to be something you do not want to have around pregnant patients. And of course, students are like, well, why would you ever have a pregnant patient being on this? It's not necessarily they're going to be on it so much as they may be exposed to it. So for instance, we treat, medications like this, finasteride, dutasteride, as a hazardous drug, meaning they could cause, hazardous drugs can range anywhere from causing birth defects to causing cancer. And so you have to make sure you're using proper PPE. So if you're having like young nurses handling this of childbearing potential, pharmacy technicians, things like that, wear gloves, and if they're going to be compounding it, and make sure you're wearing face protection, things like that. So it's still considered X, because you would not want to cause any sort of issues in terms of hormone production for developing fetus, because that can cause all kinds of developmental. There's one thing to note there. So, as I kind of mentioned, using a phosphodiesterase inhibitor for ED and BPH can be beneficial. Usually, tadalafil is going to be used most frequently, just mainly due to its longer duration of action, have less effects on the blood pressure. And then this is going to be useful because cyclic GMP actually can be contributing to that smooth muscle constriction on the prostate. So by decreasing that, by increasing the amount of cyclic GMP available, that can relax the smooth muscle. I should say, misspoke there. So that can be one side benefit there. And then the anticholinergics are going to be useful for those irritative symptoms, because a lot of the symptoms kind of mimic overactive bladder. So we'll typically start with lower doses, and then to see how we can kind of treat some of those side effects. But we just want to make sure they don't have a large post-void residual, otherwise it can worsen some of those symptoms there. So I'm going to get into that next time when we talk about urinary incontinence. So I think and then surgery could be an option here for patients who are really kind of not responding to drug therapy. But of course, you can see some complications from that, things like sexual dysfunction, incontinence, things like that. So again, outside of my purview, so you can certainly get that from elsewhere, I'm sure, with your urology teacher or things like that. But anyway, so I'm going to cut it off there for the day. There's a lot of material we covered there. So your quiz for next week be similar in terms of content and question types as before, so it shouldn't be any kind of surprise to you. You'll have to use your camera with the lockdown browser and all of that. It'll cover geriatrics, endocrinology, and everything we covered up through today. So the nephro stuff up through erectile dysfunction, BPH. Okay, so decent amount of material there. But again, it'll be things like matching, probably not true false, but some kind of sample test questions in terms of like multiple choice questions, kind of get you in the mindset for what kind of questions I could ask for this type of stuff. But yeah, so that's pretty much it. Any questions from anyone at home? What do you guys think? So the quiz will be at 8 prompt, and then yeah, that'll be it. We'll get started here online at 8:30, and then we should be good to go. Questions at all? All right. Well, if nothing else, I will let you guys go, and I will see you all next week. So if you have any questions in the meantime, feel free to email me, and I will back to you by then. Thanks a lot. See ya.